Welcome back to the Deep Dive. Today, we are strapping in for a very specific mission.
Mm-hmm.
We're tackling the essential business side of healthcare for therapists. I'm talking physical therapy, OT, and speech-language pathology.
Right. These practices are, they're the engine room for restoring function and improving people's lives.
They really are.
But, and this is a big but, they live and die by how well their office runs. They deal with a crazy high volume of prior authorizations, strict visit caps. It's a lot.
Exactly. You can be the absolute best clinician in the world, but if you can't get paid for what you do, the clinic just isn't sustainable.
And the single biggest piece of that puzzle is navigating I'd call it chaos, of payer enrollment and credentialing. It's this huge administrative wall.
It's the gatekeeper.
It is. It's the gateway to your entire patient pool, the commercial partners you pick.
Right.
Well, that's your referral pipeline. That's your cash flow.
So choosing badly can really sink you.
Oh, absolutely. You're setting your staff up for burnout and your business up for, constant financial stress.
Okay, so our mission today is crystal clear. We're going to extract the key strategies for picking commercial payers that don't just, pay a decent rate,
Right.
but that actively help you grow. So let's unpack this. What defines a really strong payer partner for a therapy clinic?
Well, we need to get past this idea of just accepting any contract that comes along. To really expand patient access and stabilize revenue, clinic leaders need partners that deliver on 5 key things.
Okay.
Think of these as like the foundation for your clinic's financial health.
I'm ready. Lay out the checklist for us. What are these 5 must-haves?
Okay, so number 1. Wide coverage, and I don't just mean they're a big national name.
You mean local?
Exactly. You need broad geographic and demographic coverage where your clinic actually is. The sources are really clear on this. Employer-sponsored plans are a huge driver of patient volume.
So you want the payer that covers the big employers in your town.
That's it. That gives you an immediate built-in patient base.
Makes total sense.
Okay.
What's number 2?
Transparent policies. This is a big one. The payer has to have explicit, clearly written policies covering outpatient rehab and habilitation.
So no gray areas.
No gray areas. You need to know exactly what's covered for PT, OT, and SLP without, having to fight them on every single claim.
Okay, hold on. Let's pause there for a second. Can you clarify that difference? Habilitative versus rehabilitative. That feels like a huge distinction, especially for, say, pediatric therapists.
It's a massive distinction. So rehabilitative services help a patient get back a skill they lost. Think therapy after a stroke.
Got it. Regaining something.
Right. Habilitative services help a patient learn a skill they never had, often because of a developmental condition. This is critical for so many pediatric SLP and OT cases.
So having clear coverage for both just opens up your practice to a much wider range of patients.
Significantly, it's invaluable.
Okay, back to the list. What's number 3?
Number 3, predictable finance. This is all about stability. You're looking for reasonable reimbursement rates, sure, but also clear fee schedules, and this is key timely payments.
Right, because cash flow is king.
It is. When we talk about predictable remits, we're talking about knowing when money is coming in so you can actually forecast your finances and, make payroll.
The difference between thriving and just scrambling to survive. Okay, what about the administrative side? The friction.
That's number 4, administrative ease. The whole process of prior authorizations, reviews, visit caps, it needs to be manageable.
It's never going away, though, right?
No, it's not going away. But if your front desk is spending 3/4 of their day on the phone with one single payer, the cost of that is just crippling your overhead.
But let me push back a little. What about a huge payer like, say, United Healthcare? They're known for tough prior auths. Isn't it still worth the headache just for the sheer number of patients they have?
That's a great question. And it leads right into number 5, which is network longevity. And the answer is yes, sometimes the volume does justify the pain. But you have to factor that administrative cost into your calculations. If that payer has good longevity, though, meaning they keep a stable network and don't just slash rates overnight, then the investment in getting credentialed is worth it.
It's a long-term play.
It's a long-term play.
So if a clinic does all this, if they build a portfolio of payers that check all 5 boxes, what's the real payoff?
It's about insulating your practice. You increase patient access because more people can afford to see you in network. You stabilize your revenue. And, critically, it's risk mitigation.
You're not putting all your eggs in one basket.
Exactly. If one big payer suddenly changes its rules, you haven't just lost 80% of your business, it gives you financial leverage.
That's a powerful way to think about it. It's a strategic defensive move. Okay, so let's move from the ideal to the real world. Who are the big players and what are their trade-offs?
So keeping in mind that local market analysis is always, always key. There are three groups that pop up again and again as strong opportunities for therapy providers.
All right, let's start with the undisputed heavyweight.
Yeah.
OPUM United Healthcare,
Yeah.
UHC.
Yeah, UHC is dominant. Their strength is just massive market presence, both with employers and on the individual exchanges. They also have explicit policies for both habilitative and rehabilitative services.
Which we now know is super important.
Right. That size means a steady stream of patients for almost any clinic.
But there's always a but, isn't there? What's the catch?
The watchouts are significant. They are known for strict, documentation-heavy prior auths. This isn't just an annoyance, it's a real drain on your staff's time.
And their payment models.
Yeah, you have to watch them. Some of their bundled or flat-rate payment models can really affect how profitable certain treatments are. You have to be meticulous.
Okay, so be prepared for paperwork. Next up, Blue Cross Blue Shield. They're everywhere.
They are. And their big strength is that broad national presence, and generally a lot of their plans have pretty robust rehab benefits. That's great for patients.
So what's the headache there? Because I know BCBS is famously fragmented.
That is the crucial limitation. The state-level variation is massive. Let's say your clinic is near a border. You could be dealing with 3 totally separate BCBS companies.
Oh, wow.
And each one has its own credentialing, its own rules, its own fee schedules. It's a huge time sink for your admin staff.
A good reminder that a big brand doesn't mean it's simple. Okay, finally, let's group Aetna and Cigna together.
We group them because they're both very strong with employer networks and on the ACA exchanges. And for practices with younger patients, they're showing growing coverage for pediatric habilitative services.
A big plus for SLP and pediatric OT.
A huge plus.
And their limitations. What do you watch for?
Again, regional policy differences. You have to do your homework. Specifically, watch out for hard visit caps or session length restrictions on certain plans. If you specialize in longer, more intensive sessions, you need to check those rules before you sign.
So getting in network is just phase 1. Phase 2 is, how do you actually work with them to succeed? Let's get into the best practices, the actionable advice.
First and most important, policy vigilance.
Meaning?
You have to dedicate staff time to this. Payers change their policies constantly, often with very little warning. You have to stay on top of it to avoid surprise denials.
That sounds exhausting.
It is, but avoiding a denial is way easier than fighting one.
True. Okay, next strategy. This one sounds interesting. Using outcomes data in negotiations. How does that work?
This is where you turn your clinical work into financial power. You have to negotiate rates using concrete, objective data.
Not just the patient is feeling better.
Exactly. For PT and OT, document range and motion improvements, functional mobility gains, ADLs.
Activities of daily living.
Right. For SLP, use standardized test scores, communication benchmarks. This data proves you're effective and justifies a higher reimbursement rate.
That's how you turn clinical rigor into revenue. Okay, what's next?
Risk mitigation through diversification. We touched on this.
Hmm.
Don't let one payer account for 80% of your revenue.
Because if they cut rates.
If they cut rates by 15%, you're suddenly in a crisis. Spreading enrollment across several strong payers protects you.
And what about streamlining things to, reduce that burnout you mentioned?
You have to focus on streamlined operations. This means things like using specialized EHR templates, standardized outcome forms, things that make it easy and consistent to capture the data you need for authorizations and billing.
So you're not reinventing the wheel for every patient.
You're not. It speeds up submissions and cuts down on denials from simple mistakes.
Okay, the final best practice. This one seems so simple, but I bet it's overlooked. Directory visibility.
It's a massive source of missed revenue. You have to do directory audits routinely?
So just checking your listing on the insurance company's website.
Yes. Immediately after any change, a new therapist, new hours, you start offering telehealth. Make sure your MPI, address, phone number, everything is accurate. If patients can't find you in their insurance directory, for all intents and purposes, you don't exist to them.
Wow. That's an incredibly practical checklist. Okay, let's get into the nitty-gritty for our final section, the inevitable hurdles. Let's start with credentialing. What's on the standard document checklist?
Well, it varies, but the core packet is pretty standard. State license, DEA if you have it, Your NTI, tax ID, a W-9, proof of malpractice insurance.
The usual suspects.
Right. Your resume, signed attestations. For SLPs, you'll need proof of your CCC, the Certificate of Clinical Competence. And if you use assistants, you need those clinical supervision agreements on file.
So keep a master digital file for every insurer.
You have to.
Okay, once you're in, you're treating patients. Let's talk billing. Give us the quick guide to common CPT codes.
Sure. For PT and OT, you'll start with evaluation codes like 97161 to 97164, which are based on complexity. Then you have your main treatment codes. 97110 is therapeutic exercise. 97140 is manual therapy. For SLP, a common one is 92507 for individual therapy.
And the takeaway here.
The key is that your code selection absolutely must match the time, the complexity, and the clinical rationale you put in your documentation.
It all comes back to the notes.
Always.
Okay, let's pivot to a really tricky situation. Out-of-network care. With all the new federal rules, how can a clinic handle this ethically and legally?
This is a minefield now because of the No Surprises Act. You cannot afford to make a mistake here.
So what's the rule?
Radical transparency. You need clear written consent from the patient. You need a publicly posted cash pay fee schedule, and before you do anything, you must give them a good faith estimate of the costs. That's a legal requirement.
They have to sign off on it.
They have to sign an acknowledgement that they understand they could be balance billed, and even then, state and federal rules might limit that. Compliance is non-negotiable.
That is vital to know. Okay, last hurdle. The dreaded denial. What are the common reasons claims get rejected?
It's sadly predictable. Usually, it's lack of medical necessity documented in the chart, a missing prior auth, using the wrong CPT code, or the patient's coverage lapsed.
Or a credentialing issue.
Or, circling all the way back, a credentialing issue.
So when that rejection lands on your desk, what's the most effective way to fight it?
Your appeal needs to be quick, concise, and data-driven. Step 1. Gather your objective, documents outcome measures, progress notes, the referral.
Step 2.
Reference the payer's own medical policy. Quote, the specific language that shows why your care meets their criteria.
Use their own rules against them.
You got it.
Yeah.
Step 3, submit a clean, concise appeal packet. And step 4, and this is important, if it's a medical necessity denial, immediately escalate to a peer-to-peer review.
And that's where all that clinical data you collected becomes your best argument.
That's where it wins the day.
We have covered so much ground. This really drives home that success in this field is where business intelligence meets clinical excellence.
It is. The big takeaway is that strategic payer selection isn't just about accepting contracts. It's about focusing on coverage, predictability, and then using your own clinical data as a tool for negotiation and defense.
So what's the final thought for the clinic leader who's listening to this right now?
I think the real engine for growth isn't about finding the easiest payer. It's about an ongoing proactive commitment to using your data, knowledge of their policy updates, and your own patient outcomes. That's what creates financial stability.
So I'll leave our listeners with this to think about.
I want you to ask yourself, how often are you proactively auditing your provider directories so you're not losing referrals? And how often are you analyzing your clinical outcomes, not just for patient care, but specifically to prepare for your next rate negotiation?
That's how routine admin work becomes real financial leverage.
That's the game changer.
A challenge accepted. Thank you for this absolutely essential deep dive.
My pleasure.
We'll catch you next time.